This talk is a guide to the psychiatric medication fluoxetine. In this talk, I've attempted to put everything a psychiatrist needs to know about fluoxetine on a single slide in less than 5 minutes. Fluoxetine is also known by the brand name Prozac, was first FDA approved in 1987, and often looks like a white capsule. It is an SSRI antidepressant and works primarily by inhibiting the serotonin transporter, thus increasing the neurotransmitter serotonin in the brain. Secondarily, it also antagonizes the serotonin receptor 5-HT2C and inhibits the norepinephrine transporter. I consider it to be a low-risk medication and a low-cost medication. In adults, it is FDA approved for treatment of MDD, PMDD, bipolar depression when used alongside olanzapine, OCD, panic disorder, and bulimia. In children, it is FDA approved for MDD, bipolar depression when used alongside olanzapine, and OCD. However, it is often used off-label for other indications. The usual dose range is 20 to 60 milligrams, and the average half-life is 10 days. Maximum therapeutic effects are usually not achieved until 4 to 6 weeks, but the initial onset of therapeutic action may be seen within 1 to 2 weeks. Due to its long half-life, withdrawal effects are rare and a taper is usually not required. However, I usually recommend a conservative approach to antidepressant tapers, reducing the dose by no more than 50% every 1 week. It does not require monitoring in healthy individuals, and it has many drug interactions, as it is a strong CYP2D6 inhibitor and a moderate CYP2C19 inhibitor. Common side effects occur in the gastrointestinal, genitourinary, neurologic, and respiratory organ systems, and are listed here. The side effects that patients are usually most concerned about are weight gain, sedation, insomnia, GI side effects, and sexual side effects. Relative to other antidepressants, fluoxetine has a very low incidence of weight gain or sedation, but relatively higher incidence of insomnia. Rare but serious side effects are listed here. Its use is relatively contraindicated if the patient has an allergy to fluoxetine, or if the patient is concurrently taking linezolid, an MAOI antidepressant, methylene blue, pimozide, or thioridazine. And it has a black box warning for increased suicidal thoughts and behaviors in children and young adults. Let's next review special cases. Fluoxetine is cleared by the liver and requires dose reductions in patients with liver impairment. It generally does not require dose adjustments in renal impairment. Fluoxetine is not a preferred antidepressant in pregnant patients and is present in breast milk. Let's next discuss dosing. For simplicity, the doses given here are those used for MDD. I'll review the usual initial dose, maximum dose, goal dose, and titration schedule. Fluoxetine may be dosed anywhere in the range of 5 to 80 milligrams. The initial dose is 20 milligrams for adults, 5 milligrams for 8 to 12-year-olds, 10 milligrams for 12 to 18-year-olds, and 10 milligrams for those 65 and older. The FDA maximum dose also depends on age and is shown here. For MDD in adults, the goal dose is 20 to 60 milligrams. And for GAD in adults, the goal dose is also 20 to 60 milligrams. For OCD in adults, the goal dose is higher, at 40 to 80 milligrams. For pediatric patients, the goal doses are generally lower. And for geriatric patients, the goal doses are the same as in adults. As you can see, in most cases, the goal dose will be from 20 to 60 milligrams. The usual titration schedule is 20 milligrams every week for adults, and slower for children. I'd like to conclude with a few final tips. First, fluoxetine has the longest half-life of any antidepressant. This means it takes longer to reach steady state, which has pros and cons. The pros are that patients can miss doses once in a while and not experience withdrawal effects, and that tapers are generally not required when stopping the medication. This can be helpful for patients who have never taken a medication before and may have difficulty remembering to take it regularly. The cons are that you have to wait longer for the medication to wash out before starting a different serotonergic antidepressant, which can lead to a higher risk of serotonin syndrome. Second, due to its strong CYP inhibiting effects, fluoxetine has numerous drug interactions. Third, patients often experience increased anxiety, irritability, restlessness, or other symptoms of psychomotor agitation soon after starting fluoxetine, which are called early activation effects. These tend to go away over time, but can make starting fluoxetine more difficult. Additionally, one of the most rigorous meta-analyses to date comparing different antidepressants in the treatment of adults with MDD found that fluoxetine was in the bottom 10 of most effective antidepressants, though in the top 3 of most acceptable antidepressants. That's the end of this talk. I hope this is a useful guide to fluoxetine. Thank you.